I tell you why I asked, because in the next few slides I just want to talk about is the importance of measurement. Phil's slide showed lots of data, and traditionally, for people like many of us who are scientists, we love the data. It's actually very difficult to engage people in data often. And that's why I think, the slides that showed swimming pools or jumbo jets are incredibly important, because generating the data is not enough. It's about engaging and communicating with people. I measured my BMI last night, and it's 22.9. It's spurious precision there. Is that good? Anyway, I'm just going to show a few slides about some of the work we've done. I work in the NHS. Is anybody heard of the NHS? Big organisation in the UK. And some of the ways in which we, as a group of health professionals, or as a very large organisation, is trying to get to grips with the responsibilities and challenges of a new world, in a sense. And it's not easy. It's not easy for large organisations. I'll just run you through a few things, and maybe we'll just ask a few questions, because I would be very interested in what your reaction to what I'm going to say is, because interestingly, I've heard a lot of what I'm going to say before. So we know that the medical scientific community is pretty much on board with the fact we can quantify it in many ways. The fact that climate change per se, climate chaos, is likely to be probably the globe's largest strategic health challenge. But that doesn't mean to say that we as individual organisations or as individuals are taking it as seriously as we should do. And my main thesis, and the main question I would love researcher colleagues to ask for, is why are health professionals not taking this as seriously as we might? When you look objectively at the data, it's pretty scary. But we all have an amazing propensity for denial. But it seems that health professionals have a huge skill at this. And I'm curious to know why that is. This is a slide you may have seen a lot, which is this is a heat wave. It's a pretty big heat wave actually in 2003. On a par with a heat wave that happened 5 years previously in Chicago, and it led to a lot of people dying prematurely. 15,000. Well, actually, it's probably about 30 to 60,000 died prematurely. Interestingly, but the reason I show this graph is because it did almost tiddly squat for European health policy, almost nothing. And it's very interesting how large numbers people can suffocate in large numbers. I always say, if you take a child to the wrong A&E unit in an ambulance, and the child dies, a named child on the front of the side with a picture of the child and his name underneath, it will change health policy. But if you show very large numbers, sometimes it doesn't. So there's an issue about how we communicate large numbers on the basis that, one death is a disaster, 10 is a tragedy, and 1,000 is a statistic. So that's very important. And we know that climate change can cause cataracts and diarrhea and vomiting and dengue fever and malaria and skin cancer and floods and heat waves. These are important things, but we always gravitate towards these, possibly wrongly, especially in the health professions we do, because they, especially the top three and skin cancer, they are isolated diseases. We're very fond of, doctors are obsessed with diseases. We're not interested in health particularly, but we're obsessed with diseases. And it's interesting how we quantify disease prevalence and incidence, but we don't look at large system change. So if you look on a global, picture, yeah, if you look at the things like drought and crop failure and economic collapse and migration and civil unrest and like happened in East Ireland, these are the things that cause thousands of deaths, millions of deaths. And in a way, they're much more important than malaria, because in a sense, malaria, you might even find climate change is good for malaria because rich people start getting malaria, and then when rich people start getting diseases, pharmaceutical companies very much accelerate their investment. So these are the really big things that cause the. I don't know if anybody here has ever been in a war zone or a disaster relief area, but it's absolutely extraordinary how quickly things change. If you were in Second City in Syria 24 months ago, you'd be having coffee in a nice coffee bar, and now it's a war zone, and it's absolutely extraordinary how these things happen. And these are the things that cause the major mortality and morbidity. So we better talk a little bit about population. Population in terms of size of the population, it's important to look at the absolute effect on climate change of what Phil was talking about, 9.1 billion people. The number of people is important, but the individual impact per person is probably more important, because 9.1 billion is about a 50% increase on where we are now. But if you look at the variability of individual impact, now I mentioned how many people have measured their BMI. How many people in this room know what their carbon footprint is? Okay, how many people who are salaried here know what their income is? Well, probably more of you. I say that in seriousness because, again, if you can't measure it, we can't manage it. And if you look at individual impact globally, comparing the United Arab Emirates, the USA, with sub-Saharan Africa, there's a massive variation, huge variation. And most of us in this room will have probably a carbon footprint individually of about, in the region of about 8 to 15 tonnes a year. And we know that sustainable personal capacity, earth carrying capacity, is only about between 1.5 and 2 for a population of 9.1 billion. So everybody, it doesn't matter how many bikes we ride or bulbs we change, in the society in which we live, we are unsustainable, absolutely unsustainable. The other issue is really about the variations in effect globally in terms of social justice. And this is some data published a couple of years ago in the Lancet about who produces the greenhouse gases. That's a cartogram to show the production from North America, Europe, on a population basis, and who bears the burden in terms of climate change associated mortality. Now I don't think you get much simpler than that in a graphical way in terms of the unethical distribution of who's bearing the burden and who's historically reaping the benefit. And the one thing that I'm sure we'll touch on a lot, if we haven't already touched on today, is the healthcare benefits. Now these healthcare benefits are incredibly important, and Phil, in a sense, touched on them in terms of the multiple angles from which obesity can be looked at, the multiple angles in which many other things can be looked at, in that what is good for the future climate is good for our health now. That's something that a lot of people perhaps don't understand. In terms of the issues around physical activity and better diet, that's the energy use and the energy intake, as you were talking about, Robin. Improved mental health, less road trauma, less air pollution, all those things are good for our health now. We would gain immediate benefits, and a lot of the work that Ian and Phil and others have done is to quantify that, because it's got to be quantified in order to have political impact. The area in which I work, which is really around the healthcare system, is even the healthcare system as a large organisation benefits from taking the future very seriously, because you can see how better models of care, more prevention, care closer to home, better use of drugs, better use of information IT, is good for the healthcare system. And thirdly, the sort of third global benefit, the third co-benefit level is around global health inequalities and social justice, just like we've seen. And it's sort of summed up by this well-known cartoon, which goes to explain why sometimes it's not always a good idea to bang on about climate change, because climate change will often drive people into denial, it'll scare people, it'll bring out the worst in the other end of the spectrum. But actually, just concentrate on those good things on the right-hand side, and only use climate change as something in your back pocket to really alert people to when they're completely resistant to it. You can often gain much bigger traction and much bigger engagement. Why would you not want to live in a world where the streets are safe, where there's food on the table, where there's clean water, where we don't get such ridiculous levels of obscene levels of infant mortality? Why would you not want to do it? And I guess what the work we've done in our unit around working with industry, looking at other sectors, not just other parts of the public sector, but the private sector, is looking at these three dimensions of the system, which is health outcomes, social outcomes at the top, money, and environmental sustainability. Now this is classically called the triple bottom line, and some of you will have heard of the triple bottom line. But this is something that really drives the business world. And it's not wise to ignore what the business world are doing in terms of their ways of looking at the future. And the great thing for the health system and the healthcare sector is these are all very mutually supportive. Very high quality healthcare system can be very cost effective and can minimise its environmental impact. And we know that because of classical traditional health economics. We know it because there's a virtuous cycle here of health code benefits between better health and environmental sustainability. And we know we can save a huge amount of money through environmental action. Now, you may not think the bottom one is important, but that is very often the way to engage people. Start with money. And we've done quite a lot of research about the behaviours of health systems and health leaders about what will get people into this. And it's not about climate change in what they think is 50 years, it's about the bottom line now. So this is quite a compelling model. Economic, social and environmental. So if you think the credit crunch is borrowing from the future, the climate crunch is stealing from the future. So it's even logarithmically bigger than that. And that's how it's classically put. And that grey sweet spot is big in the healthcare system. But it's probably better looked like that, in that the economy is a wholly owned subsidiary of the environment. It's not an equal relationship. And we know that unless you get big people like Nick Stern and others involved in quantifying the economic benefits of addressing climate change, we're not going to get there by just looking at the health aspects of it. I'll just finish with a few slides about some of the research that we've done in the unit in the NHS. And this is really a question about why, I often ask chief execs of healthcare organisations, why do they get involved in this? Because a lot of trusts, a lot of NHS trusts do get involved in this, much bigger than you would think, much more than you would think. And the number one reason is always to save money. That is a perfect entry point, a very legitimate entry point. The second is nearly always complying with regulations. So Climate Change Act 2008 and the legislation that it spawned is an incredibly important lever to get people engaged in it. Thirdly is to improve resilience. And fourthly is to enhance reputation. And the fifth one, just lest we forget what the H in NHS stands for, is to improve health. But that's not the driver, that's never the driver, neither for managers or leaders or even for clinicians. If you ask clinicians where they would come from, you know, and we've done this before, we've done big surveys of clinicians about what are the things that you as a clinician, I as a clinician can do that will make a big difference. It's fascinating what comes out. This is less clear. This is not quite as systematic a study. And it actually comes back to what Phil was saying about helping people eat better and move better. Two of the most important determinants of your health. And as you'll often hear, never in the field of human development have we moved our bodies around the world so much without moving our bodies. And eating and moving are clearly a very, very important part of that. Secondly, enabling women to have more control over their fertility. That's a global issue, and I guess you're very familiar with the reasons for that and how you get to that. Targeting prescribing on those most likely to benefit, that's because of the cost of pharmaceuticals and the eye-wateringly large carbon footprint of pharmaceuticals. Promoting a greater sense of belonging, it's a very health-promoting part of a sustainable future. Helping people manage care before, without and after specialist care. And interestingly, the last one, which is one of the most important ones, which is helping people manage a better death. What does dying look like in a more sustainable world? We invest a huge amount of resources into the last, not always very well or ethically, into the last few months and years of our lives. This is just another piece of work we've done on a route map, which is what are the things we need to get in place for large system change. And what it often boils down to is getting behaviours sorted, that's at an individual and an organisation level. Getting standards sorted, that's about use of the law, and getting innovation sorted, which is often about the use of technology. And don't find yourself thinking, I think it's behaviours, or I think it's standards, or I think it's all of those three working together. Penultimately, we've just done a public opinion survey earlier this year about what the public think about making the NHS more sustainable. The reason we did this is because when we've talked to ministers and leaders in the health service, they've often said, well, we can't make transformational changes in the healthcare system unless we have public consent, which is interesting when you consider what we've done in the last 2 years. So we thought, well, if you think that's a barrier, we'll go and ask people. So we worked with Pencheon and Ipsos Mori. We went out, we found an extraordinarily large number of people thought that not only should it be a high priority, but it's worth spending money on it now. So finally, why doesn't it? This is the question I would love to be able to answer. Why doesn't the health system do more? And it's a question I ask lots of people. One is we're very focused in the healthcare professions. We love the day job. We're crisis junkies. We love problems and putting them right. We're very, very busy, which is a great excuse for not doing anything more strategically. We're very focused on reacting to demand. We don't usually go out there and look for problems and prevent them. We love just people coming to us with problems. Prevention is by far, preventing ill health is by far the most cost effective and low carbon, but it's not something we devote about 3 to 4% of the NHS budget to prevention, which is slightly worrying. This is a worrying one. We do a lot for health already, which is called moral offset. Because we are in the health professions, and this is true for the church, it's true for NGOs, it's true for advocacy organisations, because we already consider ourselves good people, we are doing a lot already. We always claim it's the oil industry or the Chinese or the... Anyway. And interestingly, we work in systems, and certainly in this country, where we get rewarded for activity. So the more we do, the more we get paid for. It may come to you as a shock that doctors are influenced by filthy lucre, but sadly, they are. We don't get rewarded for prevention very much. And there's a picture of moral high ground, just in case you didn't know what it looked like. So, in conclusion, I mean, health professionals have done a lot around whether it was cholera in the 19th century, whether it was smoking in the 20th century, but it's yet to be apparent that we're doing a lot about what will eclipse these two issues in the 21st century. So, there you go. Finito. Questions?
Thank you. Really enjoyed that. I think you posed the question at the beginning, why don't doctors do more as individuals in relation to climate change? And I suppose the obvious answer, if you think about some of the examples you gave, doctors gave up smoking in the 1950s when Don and Peter showed that it caused lung cancer. And that had a much bigger effect than you might think, actually, doctors decided to give up smoking. Now, they were obviously convinced of the individual benefit to them of doing that. And that's the thing, I guess, you've got to get across to them in terms of climate change. And climate change is too nebulous. You've got to say, do this action, and convince them it's going to be good for them, I guess, is the policy.
Yeah, that's a very good point. It's a huge thing. I mean, the issue is that if you take tobacco as a risk factor, a lot of the benefit of changing your habits around tobacco fall to yourself as an individual. There's a little bit about passive smoking, but the majority falls to yourself. If you take action to reduce your carbon footprint, depending on how you take it, that benefit is largely distributed through 6 billion, 7 billion people, which is not good return.
But you might, I'd be interested in his talk, whether doctors have a different distribution of BMI, and whether they would take action on obesity more than non-doctors, if you like. Because I'm thinking that Lancet systematic review a year or two ago, which showed that the impact of being obese for 20 years or something had as big effect on mortality as smoking for a day for most of your life. I mean, that's obvious when you look around, you don't see obese 90-year-olds or 80-year-olds, they just don't live that long. And because the effect of being obese was pretty much the same as the effect of smoking 20 a day throughout your adult life, I mean, that's the kind of thing that, by analogy, doctors might take up. And I'd be interested if they did have a different distribution of BMI. And if you could somehow feed that into all the impacts and ramifications this is going to have on climate change, I need a bit less revenue.
Yeah.
Not to have done that yet.
No, it's a really good point. And one of the things I'm very struck by, and I'm not a behaviourist, but colleagues of mine who are behaviourists will often say that if you take our behaviours as individuals, we tend to justify them in the most creative and extraordinary ways. I mean, a classic example being that, if you really want something, you'll go and find a reason for, if you really want a new pair of shoes, you'll go and find a reason for why do I need a new pair of shoes? And you'll find it, and you'll buy the shoes. So-called, post hoc rationalisation. The reason I say that story is because I think when you see doctors poo-pooing climate change or taking absolutely no action or thinking the evidence is poor, it gives people a bizarre justification for ignoring it themselves, because every poll that's ever been taken about respected members groups in society have put medical professionals very, very high. So that gives us it gives us an authority, but it also gives us a huge responsibility to mean that our actions, or what we do as individuals, as your point about BMI, is very important. Whenever you see a doctor on a bicycle, that sends out a message. Whenever you see a doctor walking to their general GP surgery, it sends out a message. Equally, whenever you see an obese doctor driving a 4x4, 3/4 of a mile, maybe that sends out another message. I didn't know, but I think we need to know these things, and that's why I'm slightly perplexed.
On kind of on the same point, I don't know, for instance, how good the NHS is on its green record. But I was quite struck by one of the talks earlier today, M&S doing fantastic things in terms of its green credentials and so on. And that's a really good story. Whereas the NHS become increasingly more corporate. And again, that might be something that might appeal. And but actually, the point that I don't know how well the NHS is doing on this. There's lots of talk about it, but I don't know how much they've actually achieved.
Well, what we have done in the NHS, just to answer that point very quickly, is we have done the largest corporate carbon footprint of any organisation in the world in the NHS, 3 times serial data. And one of the things we do know is that in many parts, not all parts, but in many parts of the health service, the carbon footprint has levelled off and sometimes fallen, which is actually quite a staggering achievement. It's not an achievement because I don't think we've consciously done it. There are things like the recession and changing personal habits and the changing models of care and the way we deliver care. But it is pretty amazing. It is one, 3rd, 4th largest organisation in the world. It's a level off your carbon footprint. It's nowhere near where it needs to be. I think we ought not risk declaring victory too early. We're turning, supertanker is slowing down and sometimes turning, but you're right, it is massive. And we don't take, the thing that's perplexing is that there are so many other good reasons to reduce it, not because of climate change, but because of cost, because of better models of care, because of the better use of technology, more empowered patients, all the other things, non-pharmaceutical interventions for treatment and prevention. There are very good reasons to do it. There are many more win-wins. So my colleagues from Marks and Spencer say, God, it must be great working in the NHS because it's absolutely well suited to reducing its footprint and delivering better quality of care for less money. Well, it is actually, but it's a very difficult thing to frame for people where you get rewarded money-wise as if you're a clinician, and you get rewarded politically if a politician stands up in Parliament and says we've done this many more operations. A politician should not be proud to stand up in Parliament and say we've done more operations. Maybe in the traditional days of the long waiting list, but not now. We shouldn't see that as a badge of honour.
David, how many patients complain that the ward they're sleeping in is too cold?
I know what you're saying. That's one of the, a lot of people will say, public will say, why are the hospitals too hot? Why do you burn your lights all night? And why do I need to drive a long way, pay horrendous parking charges to be told I didn't need to come to the hospital? So we've got a long way to go before the healthcare system is a model of what a sustainable society can look like. We don't use technology in any way, shape or form as we could do in the healthcare sector. And that's for peculiar reasons of history, tradition, power, status, all sorts of things we haven't got time to go into. But you're absolutely right. And that's why we did the public opinion survey, because what greater sort of authority we've got than public demonstration of, it's giving politicians mandate to act, or removing their barriers. That's what it really does. It removes the barriers. Good question.